So just as people are taking their seats, it's my very great pleasure now to introduce Michelle DeGroot from the First Nations Health Authority. Now, Michelle is going to explain a little bit more about herself when she comes up to the microphone, but since I've got the mic for 30 seconds, I just want to say that I haven't known Michelle quite as long as I've known Julio, but I've had the very great honor and pleasure of working with Michelle, catching colds from Michelle on airplanes in the north, and watching Michelle chair and steer and guide some really exciting work in the mental wellness and substance use area, in primary care and public health, and in other things, as she has been a bit of glue in the tripartite process, which is a big, difficult, exciting, challenging, and daunting kind of effort, a path that we've been on together for several years now. So with no further ado, please welcome Michelle DeGroot from the First Nations Health Authority.
Good morning, everyone. I'm just going to situate myself here. I'd just like to take this opportunity to thank our elder for the prayer this morning and for the Coast Salish people for allowing us on their territory today. My name is Michelle DeGroot. I am Shkwotmuk from the Tecumseh Indian Band, and that's kind of why I'm introducing myself, because it's really hard to say those words, and I'm learning. I haven't quite got it there, but I'm getting better at it. I work for the First Nations Health Authority as the Executive Director for Health Actions, and I've been doing this work for the last quite a few years, and I think I've met quite a few of you through the years, and it's good to see you here today. So my presentation today is about community engagement and a process is how we're developing that. So it's a little bit different than Julio's. I don't have data or anything. I just have a process that we're evolving as we start moving towards First Nations health governance and us having a community-driven and nation-based approach. So the overview for today is a condensed version of an introduction to the First Nations Health Authority, an approach to engagement, and our move towards an HIV and AIDS strategic approach for First Nations people in BC. And then some next steps of what we're doing. So the 4 pillars of our governance model in First Nations Health is, one is our First Nations Health Authority. We became a society, the First Nations Health Authority Society, in August of this year. Before that, we were the interim First Nations Health Authority, which took place about a year ago. And before that, we're the First Nations Health Society. And before that, we're the First Nations Health Council. And this all happened in the last 4 years. So we've gone through a lot of change, and more change is coming, but change is good. And as part of that, the First Nations Health Council still exists. It is a 15-member body, 3 members per region, and our regions mirror those of the health authorities. Those 3 members are elected within their regional processes to represent the interests of their region. The First Nations Health Directors Association has a very similar process for nominating representatives. Once again, 15 members, 3 per region. And these are our health directors within our health service organizations at home or on reserve. Lastly, we have the Tripartite Committee on First Nations Health, which is our senior official committee. Its representatives on there are First Nations Health Council members, the CEOs of the health authorities, our board chair of the First Nations Health Authority, and our CEO. We have the Deputy PHO for Aboriginal Health, Evan Adams, and the PHO, Perry Kendall, on there. And I'm trying to think if I've missed somebody, but I don't think I have. My apologies if I have. Oh, yes, the federal government. Can't forget them. There are other things for it. We have the Associate Deputy Minister, Michelle Waugh, and his support team as well, that when we get together, we meet twice a year, and we review certain things. We highlight priorities. So building the First Nations Health Authority has been a wonderful and exhausting experience. We've learned a lot over the years with our partners, understanding your systems, still understanding your systems, and also learning how to develop partnerships and relationships. We don't have a lot of capacity, but we do have a lot of support and assistance from our partners. So we have a shared vision amongst the Health Authority, the Health Directors, and the Health Council, and that is a healthy and self-determining and vibrant BC First Nations children, families, and communities. And we all share that vision for a reason. We all want the same thing. We have shared values of respect, discipline, relationships, culture, excellence, and fairness. And we are guided by the 7 directives from our communities, and these 7 directives include, and the first one is community-driven, nation-based. Now that is not clear because it's a process to understand what that really means, as it's individual to each community and each nation, but coming eventually to a collective decision on what that really means. And it's all part of the learning process, and it's all good work that we're doing there. 2 is increased First Nations decision making. We want to be able to make decisions about our health care and about our well-being as First Nations people and what that means to us. Number 3 is to improve services, and we want to work because our communities also provide services. We want to work with other partners to be able to ensure that the services are integrated and collaborative, and that people who are accessing them are getting quality services. 4, foster meaningful collaboration and partnerships. We look to support. We can't do everything ourselves, and we understand that we need partnerships and relationships to make these changes in systems transformation and First Nations decision making. And develop human and economic capacity, that we ensure that we bring everybody along, that everybody has a chance to participate within our communities, home and away from home. And be without prejudice to First Nations interests. That one usually doesn't apply because we're not in negotiations, treaty negotiations or anything like that. But we do want to ensure that we do align when necessary if that actually happens. And then 7, function at a high operational standard. That we ensure that we do things with the utmost care and financially feasible, etc. So the First Nations wellness approach, this was developed over the last couple of years, and it's a framework to look at from a First Nations perspective, how we see ourselves and how we see ourselves in different components. So in the center we have the human being, and surrounding them is their emotional, mental, physical, and spiritual well-being, the 4 components that make up a person. And the colors mean everything in this diagram, and it's very in-depth, and I won't go into it today. But the First Nation Health Authority is designed to be a wellness partner. It's not designed to, based on an illness system. We want to look at a person's well-being and what that means, and that we want people to be well. Living the wellness model, the First Nations Health Authority is a champion for health and wellness. That's our organizational wellness is very important to us, and we want to ensure that our staff and our leaders and everyone is well, and that we want to be champions and show people that it is possible. So for some of you may know, we are transitioning the First Nation Inuit Health Branch BC region to the First Nations Health Authority. That'll happen in October. But we want to create a culture in our organization about well-being, that everybody wants to come to work. They're encouraged about the work that they do, but also that they're taking care of themselves, their families, and their communities. Commitment to support the health and wellness from the youngest to the oldest. It's a spectrum. We look at everyone. We don't want to leave anyone out. And we have a commitment to our youth and encouraging them to live well and to be well. And leading edge of systemic change by aligning with the innovation and change agenda of the province. So we are learning from Arlene and Warren and all your colleagues what that looks like, and how that we actually, our goals also align with the goals of the province. So core components of the wellness approach. Nurturing spirit. These things are great. Respecting tobacco. Being active. Eating healthy. Maintaining healthy body weight. Oops, sorry. Can I go back? There we go. So these things are all encompass one person. And I know today we're here discussing the importance of HIV/AIDS and the STOP initiative and what that means for everyone. And we look at the person as a whole, so that we're looking at whether are living with HIV or they're living with diabetes. They are encompassed with much more than that, and we want to be able to support them and be able to encourage well-being, regardless of a chronic disease or anything else that they are living with. Because it's not just that. Usually, we're maybe dealing with housing and other social determinants that we need to have support for them for. So communities as partners. Building the foundation through engagement is very important, and it has been since day one. So the first plan came out in 2006, and we were tasked with having the Gathering Wisdom, the first forum, in April 2007. And the importance of this is to understand from our communities if we're on the right track, that they're engaged, that they are actually participants and partners in this process. And it's much more. They are the service deliverers. They work on the ground, and the importance of them being able to plan and implement with others is really important. That's for a streamlined approach. We have a broad spectrum of engagement with communities. So we utilize the experience and knowledge of our health directors and their staff, health service providers, so all of you in the room and others, to try to understand if we're on the right track and we're doing the right things together. Our First Nations leadership, who has driven all of these plans and all these agreements forward, with them and their guidance and support and advocacy, we've been able to reach an amazing amount of movement in the last 5 to 6 years. Our tripartite partners, including the federal government, that they're really supportive of us. And we've gone through our challenges, and there always will be some, because these systems that we're trying to work with and change are very large and very complex, and sometimes change isn't easy, trying to move and be agile within them. And then lastly, our Aboriginal partners. We are working with the Friendship Centre Society and the Métis Nation BC, and any others that we can engage. It's been difficult because we also have post-secondary institutions and a lot of other associations who are very interested in our work, and sometimes it just takes time to involve everyone. And our 4 pillars play a critical role in engagement. So each of the health directors, the health authority, the health council, we all need to have these discussions, but we can't all just be discussing all the time. We also have to do work. We have to be able to implement things. So we're developing an engagement pathway so that we know at certain times of the year what we're doing and when we're doing it, what the discussions are we're having, whether they're political or technical, what that looks like, and is developing over the years as we learn. The last few years have mainly been around governance, having our leadership decide what it is their First Nations Health Authority looks like, what regional office or regional processes look like around offices and tables and representatives. So a lot of work has gone on, and as we move forward, the engagement may look a little different. So why is engagement so important? It puts First Nations at the front and center of health and wellness planning. Our communities have developed health plans or health work plans for the federal government to receive funding. They've done an amazing job. They've talked to the people who access their services. They've done surveys, and acknowledging that and utilizing that information to help plan at a regional level is really important. There is partnership accords in each of the regions between the health authorities and the First Nations. And those regional or those partnership accords state that they have to have regional wellness plans. And in order to create those, we need to look at and ensure we have all the information to fill them, to set priorities, and to ensure we know what work is going forward. So other parts of engagement, it informs, as I was saying, strategic policy planning and development at all levels. So whether it's at community or regional level, it also is at provincial level, and we engage around health actions for different areas to create provincial approaches or frameworks to support discussions and support development of partnerships. It builds consensus, so everybody's on the same page. Sometimes you come to a meeting and everybody comes with a different idea of the work that's set out. But through engagement and consistent engagement, everybody is able to set the common ground and to be able to move forward from there. Solidifies a commitment to collectively work together to make the systems better. So that's the intention. It's not to complicate things or anything like that. It's just to make the services better and to make people better. So engagement activities and initiatives. We have our community engagement hubs. There's over 30 in the province. This initiative started quite a few years ago, and it was to bring communities together to work together, because before they were separated, they didn't necessarily plan. There were some groupings, Shuswap, Nechaniel, Carriers, Canny, who did group together as nations or under health organizations to work together. But most of the province was left out. So we provided funding to be able to, for them to communicate, collaborate, and plan together, so that there's especially geographically, because it can be very isolating, and it helps us have those conversations. The First Nations Health Director Association has an AGM every year, so that's opportunity. We also have our Gathering Wisdoms every 18 months. The last one had about between 800 and 900 people attend, which was political and technical, and our partners, and they just keep getting bigger, and it's momentous when we have the nation entrance, and each of the regions come in and they bring their ceremony with them, and it starts our work in a good way. Our strategy tables, which Warren mentioned earlier, we bring back together partners to discuss provincial approaches and how the different systems work, and we know what each other is doing. That never took place before these plans, these First Nations health plans. The federal and provincial systems were separate, and we're trying to break down those barriers and bring everybody together to have good discussion. And regional caucus and regional tables. So this process is just developing now. We do have our regional caucuses for the last few years, and I mentioned it's Health Council membership. They also do sessions twice a year where they bring the leadership together to discuss. Those are still the advocacy pieces, those political pieces are still important, but in addition to them, we're talking about regional tables, and those agreements between the health authorities and our First Nations are really important, because they're setting up regional processes that will help guide the planning and guide the work going forward. Partnership accords, which I've mentioned. MOUs with Aboriginal partnerships. So we have MOUs with the First Nations Health Authority and our First Nations Education Steering Committee, with the Aboriginal Friendship Centre, and with a few others that we've identified common themes and common issues that we want to deal with. Community health and wellness initiatives. We provided some funding this year to our communities. It's not a lot, but it's a start, and it's something we can build on to understand where it is that other pieces of programming and services, what they're missing, and it's usually around a traditional component, bringing in our traditional practices that normally don't get funded, or gatherings that normally get funded. But when we gather as First Nations people, that we also have the opportunity to have discussions, to talk about those hard things that nobody wants to talk about, and to allow for interventions around health programming. And then we also do a lot of surveys virtually. We have a very young crew over the First Nations Health Authority, and they're very good with technology. So we like to get out there, and we're on Twitter and Facebook, if you can find us. So earlier I mentioned the engagement pathway, and this was set out by the First Nations Health Council. And there's the different components are very important, and I don't know if you can see how well you can see them up there, but it gives us an idea of how we need to do engagement and how important that is. So it is guided by the 7 directors and adopted by BC First Nations in the consensus paper, BC First Nations Perspectives on a New Health Governance Arrangement, and the principle of reciprocal accountability. So the consensus papers, they come out of Gathering Wisdom, and our chiefs vote on them, and they agree that, yes, this is how we want to move forward. So this engagement pathway helps govern us around First Nations health and how we should be doing our business around engagement. So our First Nation health directors are running community programs and services, and they're very operational. It's what they do, and they're very good at it with very little money and very little support. As we move forward, they'll be able to do more because they're able to coordinate, collaborate, and plan with each other. We have a dialogue through regional and sub-regional caucuses and meetings. Some of the regions, as you know, are very big, so they've organized them into sub-regions. On the island, they call them families because there's 3 different nations, Coast Salish, Kwagilth, and Nechaniel on the island. So they have those conversations, and the decision-making comes from them. And we help the health directors, which is a strategic level advice for province-wide strategies. So they help inform health actions from their lens as Provincial Health Directors Association. This encompasses a new level of dialogue for First Nations health service improvements. So just on that and how that ties into the work going forward around what we're here to talk about today is the importance at the regions for the health authorities and other partners, including First Nations, to have discussions about how the best approach is. And it may not look the same for everybody, and so you need to have those discussions. Those regional processes that are being set up, the tables and everything that goes underneath, to be able to have those dialogue there around HIV, what it means to our communities, the support mechanisms required to support heart or access to heart for our people is really important. I may not have all the answers today, but sometimes I'm not going to have the answers, somebody else will. And so I encourage you to have discussions in your regions. A lot of you already know or have, and I see Diana here, Vancouver Coastal, you have your table set up to have those discussions there. And as we move forward, the opportunity will increase. It'll take a little while to set these tables up and this process up within each of the regions, but it's going to get there. And that rich dialogue that you can have there and the decisions that can be made from it are really important. So from a provincial lens, we are trying to support those conversations with a strategic approach. And the history to this is there have been a number of Aboriginal-specific HIV/AIDS strategic plans and recommendations prepared over many years. I guess it's around 10. In 1999, the Red Road Pathways to Wholeness was released by the Ministry of Health. Next, in 2005, Renewing Our Response recommendations, that was PHSA who led that work. In 2009, the First Nations Health Council released Unifying and Strengthening the Responses to HIV and AIDS in Aboriginal Communities in BC. And in 2010, Aboriginal HIV and AIDS Services in BC. We want to be able to operationalize all the good work that was done for these and to look at those action items, to look at the priorities and be able to say, okay, well, this is how we need to move forward. If that suits you. So we're not being prescriptive, we're not telling you you have to do these things. We just want to pull in everything and not forget all the work and knowledge that went into these documents and be able to ensure that things move forward as we go. So our First Nations HIV/AIDS strategic approach. So in spite of all these plans, the Aboriginal population in BC continues to be disproportionately impacted by HIV and AIDS. Excuse me. The intention of this strategic approach is to be used as a framework for planning, and First Nations and partners are invited to utilize it as needed so that services and programs are community-driven and nation-based. The tripartite partners will need to drive systemic change, so we need to be able to open doors and create space for you able to do this, to plan and to implement. Some things may get in the way, and we need to know that so that we can work on it to change it, whether it's legislation or policy or whatever it may be. We want to be able to support the work that you're doing. And all the information that we're collecting is always shared, whether it's with you or with our communities. We want to make sure everybody has the same information. So the first phase is the scan and research work steps, and that's being done right now. We want an alignment of research within First Nation HIV's goals and objectives, and that's what we're doing right now as well. So research designed by First Nations activity and desired outcomes as per the logic model, which is coming up. So we are looking at everything. We want to make sure everything aligns, and we want to know just basically our lay of our land. What are we dealing with? So we have, which you probably can't really see most of this, but we've developed this logic model to move forward and to understand where it is we're going. And that's a little more detail. So we have leadership and commitment, education and awareness, testing, treatment and supporting of services, harm reduction, and surveillance and evaluation. These are common themes to the documents that have been found so far. So work will go forward. We'll ensure that, if you are interested, just let us know. It does fit into our larger scope of work that we're doing around primary care and public health, or in general health services, that this will inform a framework for continuum of care. We want to ensure, regardless of, as I was saying earlier, we want to look at the individual, whether they're an elder with diabetes, we want to look at them as a whole, or a young man with HIV. We want to be able to provide them a continuum of care from whether they're in their community to all the different steps within the healthcare system, and ensure the persons or people end back in the community where they are supported, and that community provides that support. And I just have a couple slides around Deputy PHO of Aboriginal Health, who's sitting over there, if you haven't noticed him. I haven't. And I just wanted to share a few things about the work that he's doing. So specific to Evan's role as the Deputy PHO for Aboriginal Health, a project is currently underway to identify HIV and AIDS priority action items that he can undertake and influence within the scope of his role. So lending support to the work that the First Nations Health Authority and their partners is doing, as well as to support you in what you're doing. The project is identifying policy and systemic barriers for something as fundamental as getting an HIV test in rural and remote communities. That's over the last year, we've identified some issues with our First Nation Inuit Health Branch nurses who are providing care, and how there is little barriers to testing. There's barriers to getting the tests reviewed, and all these things that we need to be able to work on with our partners to ensure that the access to anything is available to our people. So some of the next steps after this work is working with you and the other people in health authorities and everywhere else to set up regionally driven approaches to stop. Feedback on first phase of strategic approach findings, and that would be an engagement process. Whatever we find in our scan, we need to bring to people and say, okay, does this look right to you? Is this something, or are we missing something? Do we need to add so we don't miss anything? And then inclusion of First Nations first phase findings in a larger development process to a wellness continuum for First Nations in BC. Thank you very much for your time.
Thanks, Michelle. We've got a few minutes if there are folks who have questions for Michelle.
And just a reminder.
Rob.
Sorry, a reminder to come to the mic.
Which is moved over there now.
So Rob Parker, MHO with Interior Health. So as we're working to come up with, in our Interior Health Planning Committee, Implementation Committee, with the plan for Stop HIV, and we're connecting with our First Nations, our Aboriginal Health Program, and Brad Anderson, oh, he's got it, I think he's just delayed. So he's attending. Is he there? Hey, Brad. So as we develop that stuff, and I think part of it's going to be doing it under the Interior Health First Nations Partnership Accord with community as they develop their local health plans, what aspect they want on HIV, and nation-based. How does that tie together with the provincial stuff? How are we going to make sure that ties in?
So the provincial piece is just to start discussions. If your discussions start earlier, that's great, but it's not keeping you to a certain set of steps. It's just there to support, and the Interior isn't quite set up. Their regional process isn't quite set up. But having discussions with Brad, and you can bring. I have an HIV/AIDS program manager sitting over there, and she's lots of energetic, Elena, and she is able to work with you to start having discussions and see what that looks like, because it may not be the same in the Interior as a discussion in Vancouver Coastal on Vancouver Island. But,
I guess I should have said it probably for Evan. Do you see how it might tie together across the 5 geographic regional health authorities?
So actually what we're expecting is that individual First Nations might be really well positioned to deal with these issues, and others may need a lot of coaxing and information. So we're prepared to do that. And so the individual goals are going to be greatly encouraged. My central framework is meant mainly actually just for me to enable processes that they may not be engaged in, like data sharing agreements or getting provincial diagnostic codes and that kind of idea, but their work might be something else. But I'm hoping that they will be contributing ideas about how to reach their populations locally. Now, those recommendations from local peoples, there will be some synergy from village to village to village, and there may be some stuff that's unique. So the work that you're doing individually with individual First Nations is excellent. We're not meaning to be interfering with those, and we hope that those will be ongoing. In fact, the more granular your work, the better for us.
So my plug is, Evan, there's a specific workshop where you're going to be tackling some of this stuff, right? And when is it?
This afternoon at 3 o'clock.
This afternoon at 3 o'clock. And don't go to the hair salon. Thank you. Other questions for Michelle? Put your hand up and wave. Well, seeing none, I'll say thank you very much.